Hi everyone. Today I'll be talking about the Motor Assessment Scale. The purpose of this assessment is to assess everyday motor function in patients who have had a stroke. This assessment takes a task-oriented approach and assesses performance of functional tasks rather than just isolated movements. This assessment is a performance measure, and the area of assessment is activities of daily living and functional mobility. It's most appropriate for the population of those who have had a stroke, and it takes anywhere from 15 to 50 minutes to administer. It is most appropriate for the ages of adult and elderly adult, falls under the ICF domain of activity, and the administration mode is just a paper and pencil. This assessment has 8 subtests: supine to sideline, supine to sitting over the edge of bed, balanced sitting, sitting to standing, walking, upper arm function, hand movements, and advanced hand movements. It also contains a 9th item that is observed throughout the assessment called general tonus. The equipment needed to administer this assessment is a stopwatch, 8 jelly beans, a cup, rubber ball, stool, comb, spoon, a pen, 2 teacups, some water, a prepared sheet for drawing lines, and a cylindrical object like a jar and a table. There are some major steps to keep in mind when administering this assessment. First, you should score and record the best of 3 attempts. Second, successfully completing a higher level item indicates the ability to perform lower level items in that subtest, meaning they can just be skipped. For the general tonus item, the score is based on a continuous observation throughout the entire assessment rather than a single subtest. To score this assessment, each item except general tonus is scored on a 7-point scale of 0 to 6, 6 being equivalent to optimal motor behavior. General tonus is given a score of 4 if there is a consistently normal response, with a score of less than 4 indicating hypotonus and a score greater than 4 indicating hypertonus. All items except for this general tonus is summed together to obtain a total score out of a possible 48 points. Here's a demonstration of how to administer the motor assessment scale. For this demonstration, only the most difficult item from each subtest was administered. Hi Kelsey, my name's Shay and I'm going to be your OT today. Today we're going to be doing the motor assessment scale. So the first thing I'm going to have you do is, can you roll to your side for me? Sure. Perfect. Now can you sit up on the edge of your bed? Kelsey, now can you reach down to the side and touch the floor and then sit back up? Alright, now can you do that with your other side? Perfect. Alright Kelsey, can you stand up for me now? Perfect. All right, Kelsey, now I'm going to ask you to walk up 4 steps and then turn around and come back down. Perfect. All right, now can you put your arm on the wall for me and then turn towards the wall? Perfect. All right, so for this one, I need you to take your hand and touch your thumb to each finger, starting with your index finger. And I want you to keep doing that as many times as you can in 10 seconds. Do you understand? Yes. Okay, are you ready? Mm-hmm. All right, go. Done. Perfect. All right, so for our last activity, I need you to take this brush and just pretend to be brushing the back of your hair for me. So just take it back and go like that. Perfect. Here's an example of a score sheet with 4 different areas for 4 different dates of administration. Here's the criteria for scoring each of the subtests. Each subtest is broken down into levels 1 through 6, 6 being the most difficult. Here are the psychometrics for the motor assessment scale. The test-retest reliability was determined to be excellent with a population of chronic stroke. The inter-rater reliability was determined to be excellent for chronic and acute stroke. It was determined to have excellent concurrent validity with the Fugl-Meyer assessment, adequate to excellent item-level concurrent validity between the similar items on the Fugl-Meyer, but poor concurrent validity with the FMA and the item of sitting balance. Finally, here is the normative data that was determined for a mixed stroke sample. Here are some biases about the motor assessment scale. First, the general tonus item is difficult to score as there are not guidelines, so it is often left out of the assessment. Second, scoring hierarchies were not always consistent. This meaning that some clients were able to do the hardest task in a subscale, but unable to do the ones that were considered to be easier. It was found through research that only the upper arm function subscale had an accurate hierarchy of difficulty. Reliability in this assessment has only been determined for stable patients. It has also been shown that the Fugl-Meyer assessment better discriminates between levels of motor recovery, both in early recovery and in higher levels of disability. Finally, this assessment cannot be used with patients who require a proxy and is only available in 2 languages, English and Norwegian. Here are my references. Thanks for watching.